GE Healthcare would like to welcome you to the session, What is the Future of SPECT Imaging? In today's session, two industry visionaries will explore the future of SPECT imaging, focusing on two key areas of interest: transitioning to whole-body SPECT CT, 3D CZT imaging on the revolutionary new StarGuide SPECT CT scanner. Our first speakers, Professor Vineet Prakash and physicist Alexander Smout, join us from Royal Surrey County Hospital in Guilford, England.
Well, hello. Before we start, here's a disclaimer from GE about the work that we're about to present. My name's Alexander Smout. I'm presenting this jointly with Professor Vineet Prakash on our experience of implementing whole-body SPECT CT for our Oncology Bones. So we're from the Royal Surrey County Hospital, and that's in the Surrey Hills in England, and we've got three GE SPECT CT cameras. So the first is a 640 Optima, and that's our basic SPECT CT. We've also got an 870 DR, which has diagnostic quality CT, and it has the Swift scan package for extra sensitivity. And we've got an 870 CZT, which again has the diagnostic CT, and because it's a CZT, it has higher image quality, which affords shorter scans and higher patient throughput. So I'm a physicist, so I like to test these machines. Here's a quadrant bar phantom, which is a load of bars of lead. And you backlight this using a technetium flood. Here it is on the camera here. And then this is the sort of image you get from it. So comparing the different cameras, you can quickly see that the CZT image is nicer. And we thought maybe this is just an effect because the CZT's pixels are all aligned in one direction. It's like a 2D modular array of detectors. So we acquired it again with the Phantom tilted, and it still performs pretty well. So the CZT, first off, has better contrast. The noise has a different feel to it when compared to the DR. That's primarily due to the difference in how it zooms. There were more counts in the DR image, and that's because the DR has the LEHR-S collimators. But the CZT has slightly higher resolution to it. So to demonstrate that, it could still resolve a 3mm gap between the sections of the bars. And I've got a coin down there to show the size there, which is pretty impressive. So we see this improvement in image quality in our clinical images as well. So this is a technetium tetratyde patient that we've scanned twice 3 months apart. And you can see that there is that higher contrast in the CZT images. It's looking a bit sharper with the lesions a bit smaller and more focal and just nicely delineated. In terms of SPECT, we tested it with 150 megabecquerels in a PET image quality phantom, which has hot spheres. It's got 6 hot spheres, and the CZT was able to see those 6 spheres with a 5.5 minute acquisition. Whereas the same acquisition on the DR, you could only see about 4 spheres. So we decided to repeat this experiment on the DR with longer acquisition times to see whether we could match the image quality on the CZT. And these are the images on the DR with double the amount of time. So effectively the CZT is scanning with half time here. And I'd still argue that those CZT images with half time imaging are still superior to the full-time DR images. And again, this is something that we also see in our clinical images. So focusing on just a few hotspots there, they are just much more focal on the CZT, and you can visualize those much more clearly than on the DR. So in terms of implementing our whole body SPECT CT, this is our sort of timeline in doing so. So to start with, when we got the CZT back in 2019, we knew we wanted to do whole body SPECT. So we started doing SPECT, and we were very cautious in our protocol to start with. So we set up a 40-minute SPECT acquisition, and we also wanted to keep the planar whole body. So we were imaging patients for about an hour, and we quickly moved away from doing that. So we realized that we could make the scans a lot quicker, and the planar whole bodies, we increased the bed speed to 30 centimeters a minute, which is actually the fastest that you can set on a planar whole body. And we made the SPECT quicker as well. So we were doing a 16.5-minute SPECT to get from the top of the head down to mid-thigh. And this year, what we've done is we've started acquiring all of our SPECT CTs with arms up, and we've also added on an attenuation correction, or AC CT, for all oncology bone patients. And that gives approximately 0.5 millisievert dose. So the future is we'd like to stop doing planar scans, but at the moment we are still doing them. And one of the reasons for that is because that's the only image of the knees and feet that we're currently taking. So we need to audit whether we can drop that. So here are our acquisition parameters and our reconstruction parameters for all of our bone protocols. And I'm not intending to go through these right now, but this slide can serve as a reference to come back to later. Similarly, on the CT, we've got two different qualities of CT now. So everybody gets the AC CT, which is about CTDI 0.3, so that's equivalent to 0.5 millisievert, or approximately 100 megabecquerels of technetium. And then there's an optional CT that we do if indicated. So that's if we wanted to really investigate some hotspot that we saw. So now all of our patients for our oncology bones are getting a 3 field of view SPECT CT with arms up, and they also have the attenuation correction CT. And this is also useful to localize hotspots that you see, and also it does have some clinical information to the ACCT as well. So here you can see some sclerotic changes, and therefore in this patient we didn't need to go on to do a higher dose CT. So we're currently auditing whether, in fact, doing more CT has actually reduced our overall millisievert dose to the population. But it's important to note that the reporting workload has increased because we are doing clinical reports on all of our ACCTs. So I'll hand over now to Professor Vineet Prakash.
Thanks, Alex. Hello, everyone. My name is Professor Vineet Prakash. It's my pleasure to talk to you today. And for the next 10 minutes, I will now show you the clinical perspective. I will do this by case illustration, focusing on the following 3 things on this slide: the added value of SPECT over planar, the added value of AC SPECT over SPECT, and finally, the added value of CT. It's been an interesting journey for us, and at the very beginning of our SPECT CT learning journey, we were actually acquiring a 5 field of view SPECT CT. So the image on your left is the planar anterior and posterior acquired on the DR, and the spinning MIP on the right is actually made from a 5 field of view SPECT. You can see the differences for yourselves. Note that the non-attenuation corrected whole body SPECT on your right shows increased conspicuity of superficial areas such as the nasopharynx, but the deeper areas are attenuated. So planars from vertex to toes on our DR takes about 14 minutes with our protocol. The 5 field of view SPECT CT takes 5 times as long, up to 1 hour. So although we started with 5 field of view SPECT, the gain from this didn't seem to justify the extra long time of acquisition. Plus, it can make reporting more challenging without the ACCT component. So for example, the activity seen in the nasopharynx really threw us into conundrums. So with that in mind, now follows our justification for using CT with SPECT. Alex has very nicely demonstrated some of the parameters, and I'm left that on the top of the slide for there. The effective dose with the CT that we're using for attenuation correction is about 0.5 millisieverts. That's equivalent to approximately 100 megabecquerels of technetium-99m MDP. In the cream section below, on the box areas, I've enumerated why we can justify the CT. So CT is relatively low dose compared to the bone scan, approximately 1/8 for the injections that we're using. It increases the diagnostic sensitivity by increasing detectability of the deep central anatomical lesions. Similarly, it improves diagnostic specificity by reducing false positives in the upper spine and superficial areas. Also, the CT component is good enough sometimes to pick up incidental findings that may well be clinically significant and thereby alter patient management. And finally, you could consider using CT to be part of a one-stop shop approach, thereby making a major impact on the patient's journey, preventing the patient from going on to have multiple time points and further CT. So let's begin with our justification for SPECT to AC SPECT, some of which I've already talked about. On this image, you can see a rotating MIP without attenuation correction. On the right-hand side, you can see that there is attenuation correction. Can you spot the differences? You may well be able to pick out in the vertebra, there are lesions which are more conspicuous, whereas in the nasopharynx and the planar looks very prominent, but it is more blunted on the attenuation correction. So we can detect anatomical lesions situated more deeply, and the superficial lesions are less prominent. Moving forwards to this patient here. This is a 64-year-old gentleman. This is our first case for you. He's got prostate cancer, and this was a staging scan done because his PSA was 7.42, and he had Gleason 4+3 and 3+4. The clinical question was, is there any evidence of bone metastases? He didn't have any bone pain and was otherwise asymptomatic. So on the planars, what can you see? Well, other than some degenerative pattern of tracer uptake in the knees and elbows, nothing very startling is screaming out at you, suggesting that this patient has got an obvious concerning abnormality for metastases. Now let's have a look at the same patient who had a CZT SPECT reconstructions with AC SPECT. In the gray there are the parameters for those who are interested. If you look at the image again, you can now detect a lesion in the scapula and also the posterior rib. Here is an axial fused image which shows that uptake in the left scapula, which on CT correlates to a subtle but mostly a definite area of sclerosis. And this CT was acquired at a slice thickness of 1.25 millimeters, displayed as I have done on bone windows. This is therefore positive for bone metastases. It was very, very hard to see, if at all, on the other planar and SPECT imaging, and the patient was diagnosed as having oligometastatic disease. This impacted on his management significantly, and this changed his management. Here is the next case. This is another patient who has prostate cancer, and this is his planar bone scan. His PSA was rising, and he was on treatment for hormones, and the question was, where has the disease progressed? Once you can see the disease, you can then treat it appropriately. Well, clearly, looking at these planar images, I hope you can all agree that there are hot spots in the right ribs. They're quite close together and fairly linear, and you might think they're traumatic. And apart from a little bit of uptake in the right shoulder, the rest of the scan doesn't really show any other hotspots that would be compatible or worrying for metastases. Now on the right-hand side, I'm showing you the CZT acquisition. This is done as a fast acquisition of 3-field of view. Notice that we're only acquiring from vertex to the middle of the femur or distal third of the femur. I've got some questions for you on this slide. The rib lesion's obviously there, which we spotted before. The right shoulder lesion is there, which looks a bit more conspicuous, but you can all now appreciate the additional findings in the bony pelvis, the left iliac wing, the lower sacrum, and also in the vertebral column. So the question for you are these all metastases? We did a ACCT for looking at the left hemipelvis. You can see bony expansion, mixed lucency, cortical thickening, and sclerosis. And this is pathognomonic of Paget's disease. And this patient also had a lesion in the rib. What do you think about the rib on the fuse? Well, all you can say, it's fairly anterior. On the CT component, it corresponds to the costochondral junction, where there is high density on our ACCT. This patient, in fact, had had a diagnostic CT done for other reasons a month earlier, which shows that high density very, very clearly. And what we're learning here is that this is a benign pattern of calcification, and this is a non-aggressive hotspot. We now need to be familiar with the calcific patterns of costal cartilage, of which this is one. I have put an article there for you to have a look at for review. It's very helpful, showing you the different patterns of central, peripheral, mixed calcification. And we also noted on this patient that there was uptake in the right shoulder joint. That was seen both on the planar and SPECT. However, on the SPECT CT here, you can clearly see that there's circumferential uptake in keeping with an active arthropathy, and this is not a bone metastasis. So, in summary, this is a patient who actually did not have any evidence of bone metastases. He had trauma in the ribs, he had costochondral uptake in the right anterior rib, Paget's in the left hemipelvis, and a right shoulder arthropathy. And we were able to say that with confidence. Our next case is a gentleman with prostate cancer with a fluctuating PSA that was rising from his nadir to a zenith and then falling again in a fluctuating manner. His current rise was a PSA of 12, so he was considered intermediate risk of having dissemination. On this planar image, you'll all agree that there is a hotspot in the left proximal femur, and on the posterior images, there is further uptake in the bony pelvis. I'm now showing you on the right-hand screen his SPECT imaging, which shows further lesions in the vertebral column and better delineates the lesions in the left proximal femur and bony pelvis. Here is the axial SPECT CT fused component of the bony pelvis. The fused images localize the hotspots in the bony pelvis to the posterior iliac bones mainly, and the CT component shows osteoblastic mets. This is particularly seen well on the left posterior iliac bone. Here is the same patient where we've gone slightly higher up. The axial fused images localizes the spine uptake too. Facet joints, really well seen on the CT in keeping with an active facet joint arthropathy. You can clearly see the sclerosis and joint space narrowing there. Now we move to another patient where he was referred for a rising PSA in the setting of biochemical recurrence. This patient was symptomatic and he was complaining of left arm pain. And I'm showing you this case mainly to illustrate an incidental finding that was picked up on the CT component. By the way, the bone scan for this patient was plumb normal in the left arm, which is where he was complaining of pain. You'll notice on the soft tissue windows, there is a lesion in the left arm, which on interrogation with the cursor is actually a well-circumscribed fat density lesion in the subcutaneous tissues. This was the site of actually the patient's symptoms, confirmed later on clinical examination. The patient did not have Mets here, and this was actually a lipoma, which was subsequently surgically removed for symptomatic relief. So this is an example of an important incidental finding that changed patient management on the ACCT. Just mixing up a bit now, so moving away from the world of bone scans to somatostatin receptor scintigraphy SPECT CT. This gentleman had a EBOS biopsy-proven lung carcinoid for staging. The CZT image you're looking at using AC was acquired with a high-quality CT and shows widespread somatostatin receptor avid disease. If you look at his axial fused imaging, you can clearly see there is a localization to a large liver metastasis and also a bone metastasis in the left anterior rib. If you switch to coronals, you can see better delineation of the widespread liver disease, and this allows for better assessment of the percentage of liver involvement. And finally, on the sagittal images, a subtle but definite abnormality in the posterior elements of the lower sacrum/coccyx is seen in keeping with the bone metastases identified as a lucency on the CT. This can be quite challenging to view on the SPECT imaging alone. So now we move to back to our prostate cancer field, where majority of our patients get this type of imaging. This is a 71-year-old man with prostate cancer. The clinical question was bone mets. You can clearly see on the planar images, straight off the bat, you can see there's a focal uptake in his facial bones and also in the left anterior rib. How many of you will be confident to say that this is not metastases? Perhaps some of you know what this is already, but let me illustrate by showing what SPECT CT added. Here is the SPECT on the left and the fused SPECT CT reformats on the right with special windows. The SPECT infused images show bony expansion and sclerosis in the rib and in the jaw. Looking at more detail in the jaw, they have a similar appearance to the rib lesions. On CT, they have this expansion of bone with well-defined borders and ground glass opacity. This level of detail allows us to make a diagnosis of fibrous dysplasia and helps distinguish the hotspots on the scan from other entities such as metastases and other non-aggressive entities like Paget's disease. Here is the last CT image of a rib showing very nicely at 1.25 millimeter slices on bone windows, the ground glass opacity, which is considered pathognomonic of this condition. This patient, therefore, did not have bone metastases. The final case we have here is a lady who's got ovarian cancer and shoulder pain. On the planar images here, we don't see any striking abnormalities to explain the patient's shoulder pain. Here is the non-AC SPECT, which again is fairly unremarkable for any hotspots. As part of the CT acquisition, we have to do a CT scout, and some of your eagle-eyed clinicians looking at the scan might appreciate that there's some blunting of the right cosophrenic angle. And sure enough, on the CT component, you can see a right pleural effusion of relatively small volume. This patient actually had pleuritis, which was irritating the phrenic nerve, which, as you know, innervates the diaphragm, and that was actually the cause of the shoulder pain. So, in summary then, I have illustrated with some clinical cases justification for doing AC SPECT over SPECT and the added value of CT. It's a narrative that continues to evolve. Our current workflow is that we use our CZD scanner for oncology because we get better images in half the time compared to the DR. And we mainly use the DR currently for our diagnostic work. It was a pleasure talking to you, and I'd like to thank Alex and our colleagues at our hospital, and I'd like to thank you listeners for your attention. Thank you.
Thank you, gentlemen. As you just heard, transitioning to whole-body SPECT can facilitate additional SPECT images with multiple fields of view, increased access to quantitation and SPECT standardized uptake value, more accurate lesion localization classification. Now we're going to Orléans, France to hear from Dr. Matthieu, who will share one of the first ever clinical experiences with the new StarGuide SPECT CT with us.
Thank you for joining. I am happy to share with you the first clinical results using StarGuide 3D CZT SPECT systems in our unit here in Orléans. In this talk, I will talk to you about clinical information and our experience using the StarGuide system from the past year. So a few words about the technical innovations from StarGuide. Mainly 4 innovations: the digital focus detectors into an adaptive country design with a 3D ring design that you can see on this video. You can clearly see that the detectors are able to come close to the patient with an in and out radial motion and also on a radial global motion. The second innovation is a swift plan workflow, which is efficiently automated. And the third one will be the optical scout body contouring. And last one, some of you might already know, it is the smart console. So, first of all, the system is equipped with 12 digital focus detectors that are able to come very close to the patient with the motion that we described from the in and out radial motion. The detectors have been designed to reduce the lost space, especially for brain imaging, as you can see here on the anterior part of the detector with a slim design. able to acquire more of the patient. You have the comparison between the conventional and the StarGuide system, and also a slim design on the back part of the detector to reduce the NMCT space and the room layout. The Swift plan workflow. This is something that is efficiently automated. As you will see, our technologists like it very much because here you have the example for whole body bone acquisition. The technologists place the beginning of the head, the feet, the shoulders, and the hips, and the system will automatically define the different zone to scan. So once it's done on the interactive ruler, the technologists press the scan button to start the acquisition, and everything is fully automated. Once it's finished, the technologist and the physician can choose to perform or not a CT and to perform it on the whole body or only on a part of the body. The optical scout is the first step of the acquisition. As you can see, the patient is going into the gantry, and the body shape of the patient will be imaged to be able for the detectors to come as close as they can to the patient. And with the change in the table height, the patient will always be in the center of the field of view to have the better image quality that can be achieved. This is the example you can have on the 3 slides from this patient. The Smart Console, some of you already know it. This is the technologist console that is able to reprocess the raw data transferred automatically from the system and to reprocess it on transversal slices, online or offline, wherever you want, and they can send it to the application for review that you want to use, of course auxiliaries, but not only. If you want to use Advantage Window or other viewers, this is also possible too. So the evaluation phase we performed last year. When we got the system, we wanted to perform a prospective study to evaluate the image quality with this new system in comparison with the existing SPECT system we had, the Discovery 670 Pro system for all that is not cardiac exams, and also the Discovery 530C for all our cardiac exams. This study was approved by our local ethics committee and also by HRB, and this was registered in the clinical trial database. 85 patients were double scanned, optionally with an added CT. We will discuss it later on. And what I will show you today are clinical examples from this phase, just to make you the comparisons of the StarGuide systems from the actual or other systems and to show the image quality we got with this new system. First, some bone examples, of course. A 70-year-old woman referred for gonarthrosis and suspicions of Behçet's disease from the right patella. She was injected with 531 megabecquerel HDP technetium. We performed a whole body planar acquisition with a dedicated SPECT CT on the knees on the 670 system and a whole body SPECT without CT on the StarGuide system. This was lasting about for the same time, 35 minutes on the 670 and 32 minutes plus 5 minutes and a half motion time on the StarGuide system. You can clearly see that you have a better delineation of the uptakes, especially in the right cervical part, because of the close position of each detector to the spine, and also because it is fully SPECT and not whole body planar. You also see this on the lumbar spine and also on the patella with the close position of the detector. You have clearly see the better uptake of the right patella. This is something we can also see on another example, a real-life patient, a 74-year-old woman, BMI 40, referred for left knee pain after prosthesis, injected with 928 megabecquerel of HDP technetium. Same protocols, and as you can see, we do have, of course, a better image on the whole body SPECT for the knees compared to the whole body planar acquired on the 670. This is mainly due to the SPECT acquisition. And we can clearly better see the uptakes beside the prosthesis. And if you have a look on this native SPECT image without attenuation correction, you have a clear uptake beside the prosthesis on the right part of the tibia, and also you have a clear delineation of the uptake of the right part of the body on the right knee on the gonarthrosis that is shown on the CT. But it's not only the case in the knees. You have also a better visualization of the other spots that you might have, especially on the spine, cervical and lumbar spine, and also on the feet, as you will be able to see on the tarsi and on the metatarsophalangeal articulations. And this is mainly due to the full SPECT acquisition that we have in this patient. Other example, 90-year-old woman referred for vertebrae fractures characterization. She was suffering from breast cancer, 611 megabecquerels HDP technetium, and a torso acquisition lasting for 19 minutes on the 670 system, and a torso SPECT without CT on the StarGuide system. This was a long acquisition because of the list mode acquisition. We wanted to show how far we can go with the time reduction. This is just a first step, of course. So we had 3 steps acquisition on this torso patient, 8 minutes by step, so 24 minutes acquisition with 2 minutes of motion. And we tried to make a reduction with 6 minutes by step, 5 minutes by step, and 4 minutes by step using the StarGuide system. And you can clearly see that we have higher resolution images, especially for the costal uptakes. We can clearly see them even if we go to the 4 minute by step images. This is very high quality, and now we do use in the routine the 5 minute step acquisition on our whole body SPECT on the torso part. This is what you can see on these images. While you are acquiring on StarGuide, whether it is for bone or other examples, you can perform focused imaging. This is just a slide to explain you the difference of the body contour acquisition, which is done for the whole body part of the torso acquisition I showed you, and the focus acquisition, where you want to acquire 80–90% of the SPECT image on a dedicated area, which might be the vertebrae as shown in this example, but not only. I will show you this example of extremity SPECT CT with dedicated acquisition with the focus on the ankle. So here you have the 670 classical SPECT and the StarGuide in uniform mode with the body contour SPECT on the feet, and also with a right ankle focus. You can clearly see that you lose some information on the left feet, of course, but you gain some details on the right foot, and especially on the right ankle. And you can clearly see on these SPECT CT registered images that you have a good definition of the uptakes and of the arthrosis in this patient after multiple fractures and osteochondral injury. So here with the motion, it's easier. Other example of bone, just to show you that you are able to go far from the native SPECT images, especially with the frame processing images. This is an algorithm that integrates the CT data. This is an example of a 58-year-old patient referred for prostate cancer staging, injected with 899 megabecquerel technetium HDP. We performed the whole body SPECT on StarGuide and a CT on the torso part, which was able to reconstruct and to reprocess frame images, as you can see on this slide. So you have a better delineation of all the vertebrae uptakes and especially of all the bone uptakes. And this is very nice in this normal example patient. So this is the story of a cardiac example. A man, 65-year-old man, referred for coronary artery disease evaluation with an history of bypass graft surgery. The patient was acquired with 220 megabecquerels of tetrophosphine at stress and 424 megabecquerel at rest. 10 minutes stress and 5 minutes rest for the acquisition on the 530 dedicated camera, and 12 minutes at stress and 6 minutes at rest using a focus mode on the StarGuide system with a CT for attenuation correction. You can clearly see that you have the same semiology and the same informations with a stable scar in the inferior wall for this patient. And you see that you have the same diagnosis with a bit more time, but not too many on the new system. Other example, the 42-year-old woman, BMI 53, referred for coronary artery disease screening. She was suffering from diabetes and obesity. She was injected with more activity and an acquisition that was, of course, shorter, 5 minutes on the cardiac dedicated system and 8 minutes on the StarGuide system. And you can clearly see that we have the same information and same diagnosis, which is a normal scan. And this is important to have a normal stress scan in this obese patient. Other example, tomographic RNA. We do perform a lot here in the unit. This is on an oncological indication, a follow-up of LVEF for breast cancer, injection of 300 megabecquerels of albumin with technetium, 8 minutes scan on the cardiac dedicated CZT system, and 10 minutes on the StarGuide system. You can clearly see that we have a good image quality and the same parameters and no major differences in LVEF. I invite you to see the presentation we do have on this Congress in the New Kids on the Cardiovascular Block session, talking about StarGuide for acquisition of the tomographic RNA. Other part, brain imaging, DAT scan imaging, 72-year-old man referred for extrapyramidal syndrome. This is normal DAT scan, acquired with 120 megabecquerels DAT scan iodine 123. 35 minutes acquisition on the 670, 24 minutes net acquisition time and 40 seconds of motion on the StarGuide system with a focus on the striata, focus acquisition, as we already discussed. And you can clearly see on those native SPECT images with only a Chang attenuation correction, no CT, that we do have the same clinical information and a great image quality using the new system with higher resolution. Also, we do have a talk on this Congress in the new imaging equipment and techniques session. So I invite you, if you want more details on DAT scan and StarGuide, to show this presentation I will have. Other example, some kidney, 52-year-old woman referred for renal insufficiency. We wanted to have a renal function evaluation. So we performed a static acquisition on the 670 and a 12-minute acquisition in a focus mode on the two kidneys on StarGuide with 40 seconds of motion. And you can clearly see that the relative evaluation of the renal function is the same, whether it is done on the Planar 670 and also on the StarGuide 3D SPECT system. And we clearly have an advantage for the evaluation of the upper right pole of the kidney with the new system because of the SPECT definition and the SPECT analysis in this patient. Other main advantages of the StarGuide system is the thick CZT crystals, 7.25 millimeters, into the design that we already discussed. And this is something very interesting for us, especially for medium energy. Whether we are talking about lutetium, we can image both lutetium peaks and also for indium, and which what we currently do on the unit, it is a krypton imaging for lung scans. I wanted to share with you a few examples of lung scans. This is an example of 69-year-old woman, which was known to have pulmonary embolism. It was a reevaluation, a monitoring. And this is a comparison of the perfusion done on the 670 and on the StarGuide system. You can clearly see that we do have the same information and the same evaluation of the defects on each system. 15 minutes SPECT CT acquisition on the 670 and 10 minutes on StarGuide, both in dual isotope. So this is quicker on StarGuide. And I wanted to show you some normal and pathological examples. So I will begin with the normal example of a 23-year-old woman, BMI 48, which is quite high, scanned on StarGuide, 185 megabecquerels of microaggregates of albumin with technetium and krypton breathing, 10 minutes acquisition, and here you can clearly see the very nice images, both for perfusion and for ventilation, with krypton, with the medium energy, thanks to the thick CZT crystals. And of course, a pathological scan on a young man, 38-year-old man, BMI 25, suffering from pulmonary hypertension. And you can see the multiple pulmonary embolism defects on this patient that is seen on the perfusion scan. Other example of a 35-year-old woman for parathyroid imaging, also done in dual isotope with technetium, MIB, and iodine 123. We had a parathyroid adenoma at the right inferior pole of the thyroid, which was removed by surgery. You have the 670 SPECT CT of 22 minutes and the StarGuide 15 minutes dual isotope SPECT, and you can clearly see, especially on the subtraction SPECT, that you have a higher resolution using StarGuide with a better definition of this right parathyroid adenoma on the SPECT images. I wanted also to share with you some lutetium imaging. These are images from Professor Yagaru in Stanford, so thank you for him to sharing these images. This is a patient receiving cycle 2 out of 4 of lutetium octreotide therapy for neuroendocrine tumor with liver metastasis. And something that is very interesting with StarGuide is that due to the thick crystals, you can image both lutetium peaks, and you have a great image quality with high resolution, as you can see here, in only 5 minutes. So acquisition lasted 15 minutes on the 670. Also on StarGuide, but like we did on BoneScan with list mode acquisitions, they were able to resample those acquisitions into 7 minutes and a half and 5 minutes images, just to see if we had the same clinical information. This is the case, and you still see the liver metastasis with great image quality. And this is something that is very interesting, to have this imaging with high quality, both peaks acquisition and a short acquisition time. So take-home messages. StarGuide 3D ring CZT systems provide high image quality and high resolution in comparison with the other systems available right now. This is full 3D native SPECT images, but we can also perform some post-processing like FAME I showed you. We are able to acquire in simultaneous dual isotope mode, which is very helpful to reduce acquisition time in patients. And although the thick CZT crystals enable medium energy acquisition, especially for krypton here in the unit, but also for lutetium-177, which is the very next feature when we are thinking about theranostics. Thank you very much for your attention.
Thank you to each of our speakers for their wonderful presentations. We now have a better understanding of the future of SPECT imaging. We are definitely seeing an evolution in digital and other innovative technologies, with 3D SPECT imaging and the development of theranostics poised to help deliver better patient outcomes and advances in personalised medicine. We invite you to learn more about digital technology and how the future of molecular imaging is personal at the GE Experience at EANM’21 Virtual.